Thank you. Good morning, everyone. Members, officers, and all our visitors. Welcome. And to Sarah, who I see is sitting at the back. Good morning. So, first of all, can I have permission to sign the minutes of the last meeting, which seems ages ago, but it was September. Everything all right on the minutes? Fine, thank you very much. Now we need apologies for absence, please.
We've had apologies for absence from Councillor Welsh, with Councillor Pringle substituting, and Councillor Welsh's other reasons.
Thank you very much. Thank you. Now, I'd like to welcome Councillor Nigel Turner, who is now becoming a member of this committee permanently, I say, and a welcome to Councillor Pringle in place of Councillor Welsh this morning. Is this the first time you've been on Health Scrutiny? There. Hope you enjoy. Right, so moving on. Declarations of interest. Anybody have any interest to declare? Yes, Councillor McGrath.
If you could use your mic, please. Oh, sorry, yeah. My daughter's a nurse.
Thank you. Anyone else? Councillor Eddie.
My husband's a community staff nurse.
Thank you. And I have a daughter who works in NUH. So I think that's all declarations declared. Just to mention, Councillor Eddie and I haven't fallen out, but she usually sits here, but she's full of cold and she's got a chest infection, and she suggested that she sat away from me. So I have to say, I agreed. So let's move on. I would like to, with the permission of this committee, in order to suit our guests, I'd like to just move the agenda slightly and move the acute stroke service update, of which we have Lucy Dadge, who seems to be a permanent fixture in our meetings, and Professor Nicholas Sprigg. They have to go. Well, Nicola does. So, with your permission, do I have your permission, everybody, to move this item forward? Thank you. Right, over to you, Lucy and Nicola. Thank you for coming.
Hello, thank you. I'm Lucy Dadge, Director of Integration for the Integrated Care Board, and I'm just going to introduce this paper and then hand over to Professor Sprigg to take you through the details. So just by way of background, in June 2020, at the height of COVID, we advised the committee that in July 2020, acute stroke services would be moved to QMC campus from City to help manage COVID-19 risk. We also informed you that both NUH clinicians and regional and national stroke strategies suggested that a permanent co-location of all acute stroke services on the QMC site was probably the right configuration of services in the longer term. But we did agree that we would come back to you to update you on the impacts of this change that was made under emergency powers during COVID, particularly looking at the impacts on clinical and quality of services, but also and particularly the experience of patients in their care and their carers following this relocation of services. So you've had the paper, and I'm going to hand over to Professor Sprigg to take you through it. But just to say that from the Integrated Care Board and NUH as our partners, our recommendation would be that, subject to your scrutiny, that the co-location of acute stroke services to the QMC site becomes a permanent solution.
Morning, everyone. So I'm Nikki Sprigg. I'm a stroke consultant at the acute stroke service, and I'm also a professor of stroke medicine. So I'm working on research trying to develop better services and treatments for our stroke patients. So as you've already heard, we moved from the City campus to Queen's Medical campus, and this was done as part of the COVID reconfiguration, but it was something that we'd already been thinking about for quite some time and had been recommended by a number of national bodies. So there's something called Get It Right First Time, which is aiming to get patients into the acute services in a timely manner. And then there's also something that's just come about called the Integrated Stroke Delivery Network. And apologies, but just a little bit of background. So 1 in 4 people will have a stroke in their lifetime, and there's a real momentum behind time is brain. So that means basically for every minute when you're having an acute stroke, 1 million brain cells will die. And we're trying to get the message out that minutes save lives, and they also save memories and leisure and activity and quality of life. So there have been a lot of developments in acute stroke treatments over the last 10 or 15 years, and the 2 main ones of these have been what I've called clot busting thrombolysis and clot retrieval thrombectomy, and these have really driven quality of care in stroke. And prior to this move, we were based at City Campus, and we had a service that was able to deliver these, but with big delays, because there are 2 access points for people with stroke. One is people call an ambulance, and you may have seen the Act Fast adverts on the TV where someone has fire in their face. And the ambulances now triage stroke patients and do a direct referral to us. We have a red bat phone, they call us, we know the patient's coming in, and we meet them at the door. And we were doing that at City Campus, but unfortunately a number of patients needed more specialist care and would need to be transferred over to the Queen's Medical Centre, or those that access the pathway in the second way, which is they call 999 themselves, they call a taxi and go to ED themselves. Actually, we're having to be ring-roaded around from the Queen's Medical Centre to City, and then if they needed specialist care, going back. So the advantages of moving are geographical in that we're now co-located with the CT scanner. So when someone has a stroke, it's a clinical diagnosis. So again, you'll have seen the adverts: paralysis, lack of speech, etc. But the diagnosis needs a CT scan, and it used to be that guidance was within 24 hours, then it's within an hour, and now it's literally next on table. So if we've got someone on the CT scanner, we take them off and we put our patient on next, and that's because even 5 minutes can make a difference with how disabled someone will be. So actually at the City, we were having to walk 16 minutes to the CT scanner and back. We're now at the front door of the emergency department, literally next to the resuscitation CT scanner. We wait, we literally go next on table. So the delay the lack of delay is massive. In addition to that, the approximately 10% of patients that need really specialist care are now also located at the Queen's Medical Centre. So neurosurgery, mechanical thrombectomy, etc. And in keeping with this move, we've been able to get a massive service development project to expand our mechanical thrombectomy. So this is where people will go to surgery straight from the emergency department. They'll have a CT scan, it will confirm a blood clot, and they'll go straight for surgery to retrieve the clot. And prior to this treatment being available, and prior to us being on the Queen's Medical Campus, even if we delivered this treatment, people would have at least a 40-minute or an hour delay to get to Queen's Medical Centre, to get to theatre, etc. And in actual fact, that meant a lot of patients missed out on treatment, whereas now we see them at the front door, we go straight onto the CT scanner, and then we go straight to theatre. So it really is working very well. In addition to that, for patients that aren't able to receive this kind of therapy, we're able to run, so we're now what's called a hyperacute stroke research centre. So we do clinical trials, a bit like you would on an oncology unit, and you get access to the new chemotherapy. We're giving our patients access to the new treatments that are being tested in international clinical trials. And the case report K in your letter is a patient I was involved in. Someone that came in, was assessed for this specialist care, wasn't suitable, and was then able to go on to receive a drug that's being tested in a international study. We weren't able to do any of this before the move. With regards to asking patients, so we've, as I say, been thinking about this move for quite some time. There's been some tomorrow's NUH surveys and work done with patient groups, and there's also been some stroke specific surveys. When we do our stroke specific surveys, we have to be careful that we ask patients and their relatives, because unfortunately some patients are left with communication problems, etc. And overall, we found that the quality of the care we're able to deliver, so I've already given you examples with regards to time to treatment, has been maintained, but also the satisfaction from patients. And we've always, to be fair, had good quality scores from the majority of our patients, and that is the same or even better since we've moved across. So the feedback and the patient experience has been good. From the point of view of where we're going with this now, there is, as I'm sure you're aware, massive pressure on the front door of the NHS at the moment. You will have seen about ambulances and delays. Because we're now co-located on the emergency department, we have one bed in resuscitation that's kept purely for stroke patients, so we're able to see patients straight away. So the other thing that you may not be aware of the between 5 and 10 suspected stroke patients we see a day, at least a third will not have had a stroke. And previously, if they were seen in the emergency department, transferred over to City, and we realised they hadn't had a stroke, they were often then at the wrong hospital, and they would either not get the right care or have to be transferred back. Whereas now we can do what we call an in-reach service, where we see them in the emergency department, and then we're able to decide, are they a stroke? If so, they get rapid access to treatment. If they're not a stroke, then we can redirect them to the correct service at the front door. So the work we're doing is around the front door and how we make sure patients that either present directly to us or present themselves to the emergency department, and that has gone up. People are not calling an ambulance as much as they used to. They're getting in cars and driving to the emergency department themselves. Again, because we're co-located, because we're there, we're able to see these people more quickly. I think they were the main issues I wanted to highlight. I'm very happy to take questions or expand on anything I haven't given enough detail in. Hope that's been helpful.
Thank you to both for that presentation. Very interesting. As I sit here, it would seem to be the obvious move, but I'll open it to the committee in a minute. My question, as always, is car parking.
Okay.
Have you got the facility to have people park at Queen's and come to see
So
their
I
relatives?
did suspect car parking would be an issue because it's something that we hear about all the time for patients that come to see us in clinic and on the wards. In the emergency department setting, it isn't a problem because people can pull up outside. There's an emergency waiting area. If people are in as a longer term, then there is an issue with car parking. But in actual fact, since COVID, because for safety reasons, we're reducing the amount of time that people are allowed to visit and we're spacing it out, it is actually less of a problem than it used to be. So whereas we used to have open access visiting, we now ask patients' relatives to make an appointment. So it is definitely less of a problem, but it is still an ongoing issue. As you may be aware, there are big redevelopment plans within the car parking at Queen's Medical Centre, and I can't give more detail than that, I'm afraid. But you're right, it is still an issue, but it's actually less so because of the patients, visitors being allocated specific slots, and the idea of that is so that people don't all come at the same time. So we now have patients spread throughout the day and the evening. The other thing to say is the hyperacute, which means the first few hours, and the acute, which means the first few days, is still at Queen's Medical Centre. But actually our longer stay beds are either at Connect House or at Nottingham City campus on Daybrook ward, so parking is less of a problem then. So the patients that are staying in longer, who will have obviously visitors coming for a longer period of time, are actually not at the Queen's Medical campus.
I think on behalf of residents of Nottinghamshire, I would ask, tomorrow's NUH project is going to be many years. So what time are you looking at to enlarge a car park? Because it doesn't matter whatever it's for, ophthalmology or whatever, there's always the problem of parking. So what time factor are you hoping this car park will be ready?
I honestly can't answer to that, I'm afraid. I'm a clinician. I'm aware of the plans to redevelop the car park, but I'd have to get back to you with the details.
I think this is important
I
because
completely agree.
while we're discussing NUH, tomorrow's NUH, nearly every meeting, things are being exchanged from City to Queen's, Queen's to City. And as has been mentioned by Councillor Adams as well as myself on many occasions, this is a great concern. And people who've got patients in Queen's really do want to know that they can visit and not spend all the visiting time driving around looking for a car park.
Absolutely. I completely agree with that. As I say, it is less of a problem because people are getting allocated visit slots, but absolutely it is important.
Okay, thank you. Councillor Martin.
Yeah, thank you, Chair. Yeah, I think it's great to see. It's a great piece of work. I'm glad to see that the services have been co-located and it expedites the process, and that can only be good. I am glad to hear that you've got a back phone for people who've got stroke and stroke conditions in an ambulance. What more concerns me is people presenting themselves at ED and that the assessment process there, whether that's as quick as it possibly could be, because everybody knows that coming into a busy ED department, especially on a Friday or a Saturday night, would be a difficult situation. My other concern is, I know you may not know, but you will, Lucy. Does Sherwood Forest Trust Hospital have the same kind of facility? And how are we directing people when they're phoning in, bringing their own transport, dropping off? How are we pointing them in the right direction to which facility?
I actually think Dr. Sprigg can probably answer both questions because we have for a long time had Sherwood Forest and NUH as the specialised centre working together as a network. So
yes, sorry, I should have said that in my overview of the service. So the way the service works is we're partners. As a doctor, I cover Sherwood Forest Hospital and they cover us. So the thrombolysis service, which is the drug clot busting treatment, is available at both trusts 24/7. The thrombectomy service is a regional East Midlands service, and Nottingham Queen's Medical Centre is the hub for that. So if a patient presents to any of the East Midlands services, including Sherwood Forest Hospital, they are then ambulanced in. And that's part of a national reconfiguration where we've developed a hub and spoke model. So with regards to patients presenting at ED, you're absolutely right, that is an issue, and the numbers have gone up quite dramatically, particularly due to the publicity around ambulance waits. Because we are now at the same campus, that is mitigating the effect in some regard. We're also doing a lot of training and working with our ED colleagues. Two other kind of geographical things in addition to having this one bed in resus. So I don't know if any of you have been into the resus department. So basically when you come into ED, there are 8 emergency highest level beds where trauma, heart attacks and strokes come into. So we have one dedicated bed there. But then within the major unit, so that's called majors, where people that are medically sick are, we actually have an office now, and we have advanced stroke nurse practitioners in there 24 hours a day. So as opposed to previously at City Campus, they had to ring us and we give telephone advice or patient would be transferred over. When we first moved, we didn't have the stroke nurse practitioners in ED. They were on the ward and they would go down. Now they're physically based there. So we are working on that. There is a recognition nationally that there has been a delay to people accessing acute stroke services because of this ambulance issue, and it is something that we look at every single month. We look at our metrics. We very clearly look at our pathways, our 2 groups of patients separately, because patients that come to the ambulance resuscitation bed, they're seen immediately. There's a delay, as you've alluded to, and so we look at both sets of figures rather than merging the data and being confused as to how well we're doing. So there are challenges to that, but it is work that we, as I say, there's a weekly front door pathway meeting. We review every single patient where there's a delay. We have national targets for daughter needle time, etc. So it's something we're monitoring very closely. With regards to Sherwood Forest, as I've already said, patients get 24/7 thrombolysis, which is the clot busting drug treatment. We're on call for Sherwood Forest out of hours and at the weekends, and if a patient needs to be transferred over, they're transferred over. And usually if they're transferred over, they would go straight to theatre if that's what they need, and then come to us while they're stable, and then they go back to Sherwood Forest. So there is equity of care for that hospital.
Yeah, only on one issue, and that's staff retention and staff recruitment.
Yeah.
How are you finding that?
Yeah, so that has been a big problem. So as part of our national audit data, which is called SNAP, 70% of stroke services have got staffing shortages across the board, and that has been a real issue for us. Having said that, this move to Queen's Medical Centre, whilst it was, to be honest, initially unpopular with some members of staff because they live to the north of the county, actually it's been very exciting for the stroke service, this expansion of the mechanical thrombectomy. We're able to attract consultants. We've got a consultant coming to us from Birmingham, which is another regional centre, which we weren't able to do before when we weren't co-located. We're now about to appoint another 2 consultants. The nursing role, and nurses have a massive role in stroke care, is now more attractive attractive because of this advanced nurse practitioner that works with ED. And then we have spent quite a bit of money after we moved over working on a therapy gym because it's so important to patients. And we rightly focus on the first few minutes when a patient comes into hospital, because if we can get that bit right, the brain damage will be less and they'll need less therapy. But actually, patients don't remember much of that. They remember the weeks and months where they have to have physiotherapy and whether they've got a dedicated gym and things like that. So we've had a dedicated gym, a kitchen, etc. And again, that is attractive to therapists. It is challenging, I won't lie. It's very difficult at the moment for all groups of staff. One of the other things that did happen with the relocation is it took us a while. So whilst we made sure, obviously, that the clinical services were up and running the day we moved, to get office space and things like that has been challenging. So it hasn't been easy, but I think the exciting rewardingness of it has helped to retain staff. But it's a work in progress.
Thank you very much. Councillor Adams. You did want to speak, didn't you? Oh, I thought you did. I'm so sorry. Councillor Wilmot. Can we just limit a couple of questions, Councillor Wilmot, and you can come back?
Yeah. I'd just like to congratulate actually the Health Watch in their undertaking that consultation engagement. It's been great to know what all the ethnic minority people know, or their answer to the view, and their view is that very very much so that they for the change in movement from the city hospital to. Yes, my question is about parking, unfortunately. Yeah, we all know there is a major problem. Has the NHS ever thought about looking at designated areas for stroke people near to where the entrance is, and all the others having actual areas where it's designated for each problem area? Has it ever been thought?
So,
And obviously, we're all upset about the possible strikes or whatever that comes up, and we know that so many nurses are leaving at the present time. Does it concern you on that in your area that there could be a possible problem?
So first of all, for parking, as I've already said, I can't give great detail about that. But at the front door, when the patients come in the first few hours and they're treated in the emergency department and on the hyperacute stroke unit, there is a space where people can park near the resuscitation area, and we do not have problems there. And we're very proactive, such that if patients are worried or their relatives are worried about that, we have a relative area literally at the front door where ambulances pull in, and we're able to reassure them, we're able to speak to security, etc. So I don't want you, I'm not downplaying the issue of car parking, but at the front door when people are having their emergency stroke treatment, it isn't a problem, and relatives are able to come in and be with their families and the patients there. For patients that are staying longer, it is sometimes frustrating for people to find car parking spaces. With regards to whether the trust has thought of specific areas other than kind of hyperacute emergency rather than specialist kind of stroke versus gastro versus respiratory, I'm afraid I can't answer to that, but I will take these questions back and ask for a detailed response on them. With regards to strikes, I agree that is a great concern. We had a trust briefing on it yesterday. I would say that the stroke service, which I suspect is not different to other services, but obviously I can't speak outside of my own service, we're really passionate about our patients and we want them to have the best care. As I've said, it's challenging but rewarding. I mean, it really is dramatic. When I started in this job 10 years ago, the patients we're seeing now would have come in and either died or been in hospital for months and gone to a nursing home. Some of them are going home the next day, the next week. I mean, it is so rewarding, and you can imagine how patients value that and their families value that. So that side of the service will not be affected by strikes. It's clearly emergency. Having said that, there is a knock-on effect for everything, as I'm sure you're aware of. So there are ongoing discussions to try and avoid a strike if at all possible. We will absolutely make sure that the front door is safe and that these hyperacute treatments are ring-fenced. But that will have a knock-on impact on workload further down the line. So, as I say, there was a trust briefing on it yesterday. It's something we're watching very closely, but I can't give any stronger reassurance than that, I'm afraid.
Thank you very much. Councillor Pringle.
Thank you, Chairman. I welcome the positivity in the report and the way you speak, passion, positivity, fantastic. Really, really do applaud you for what you do as well. In actual fact, there's probably never been a better time to have a stroke, I would assume, with the care that you're able to provide. Two questions, which I'm not expecting to answer. Can we improve the parking facilities? And when will it be implemented? I know we've answered that several times this week. But point of clarification on page 26, point 6.3, it says just over half of access stroke services, that 59%, so 41%. I wasn't sure how the other 41% tallied in them figures.
So I think with regards to that feedback, we tried to get perspective of people that have had stroke care before the move and after the move. So I think the majority of the people that aren't in that 59%, so the 41%, are people that had a stroke before the move. So before this, but there were some people that hadn't had a stroke at all. I can't give you the exact figures. We can find that out for you if you want. Does that make sense? Yeah.
Thank you. Sarah, did you want to make a comment on this? Or?
Thank you, Chair. My only comment, I guess, is in terms of how the service will continue to monitor the patient satisfaction with the move and any impact that we see from the distance people are having to travel. Obviously, time is of the essence, of you've really eloquently told us. So, yeah, that's mine from a Health Watch perspective, is to understand how much patient engagement going forward we can see in terms of ensuring that the service is relevant to people throughout the county, and that's being monitored for satisfaction.
Yeah, thank you. So sorry, I did have in my notes, but I forgot to say. So we did spend a lot of time thinking about patients at the north of the county and would they have to travel further. And this alludes a little bit to the earlier question about Sherwood Forest Hospital. As I say, it's a national level, in fact, internationally, really. It's been accepted that it is worth travelling slightly further to get specialist care. And there's really robust data on that. And that's because of this thrombolysis thrombectomy. So, at an emergency medicine and ambulance point of view, the ambulance will take you to the nearest hospital to provide thrombolysis. And then you will be if that's not a thrombectomy service, and as I say, Queen's Medical Centre is the only thrombectomy service in the East Midlands, you will be what's called drip and ship, which means you'll get the medical treatment, the thrombolysis drug, and then you'll be shipped to the mother centre to get that. We did wonder, because of obviously Queen's Medical Centre being further for the north of the county, if more patients would go to Sherwood Forest and then have to be moved. And I think you'll see in there the data is, I think it's 0.16. In actual fact, that's probably less than we were expecting, and it is something that we will continue to monitor. We have a joint, as I say, we work with them in partnership. We have a joint stroke governance and stroke data group. We also monthly review our metrics, door to needle, time to ED, time to scan, things like that. And we, on every single patient, do what's called the friends and family test, where we ask them, would you recommend the service? How would you rate the quality of service? And they have the ability to provide comments. And with regards to a further specific question with regards to the move, as I say, the plan is to monitor the friends and family, but I will find out if there's a further specific other than what's going on alongside tomorrow's NUH. Hope that answers the question.
Thank you very much. So, moving on, if we don't have any more questions, members, we are told on page 26 that patient experience continues to be positive. The patients appear to be supportive in this move, and we are asked to formally support making the service relocation permanent and bring consideration of this change to a close. I'm going to take a vote on this because it is a major change. So all those in favour of this, can I see hands, please? So that is unanimous, Lucy. Thank you. Thank you very much.
Thank you very much, and thank you for the opportunity. We will get back to you about the car parking.
Thank you very much. So you're going now, Professor Sprague, are you? Right. And we're bringing in now, we're moving on to winter pressures. Who have we got? Thank you very much. Thank you.
I'm hoping that I've got a colleague who will be joining us. If you could just
Yeah,
bear with us.
If not, we can always swing it around a bit more.
we can move on to the neonatal.
Do you want to move on to neonatal?
Again, I think we were expecting
Yeah.
Dr. Lewis and.
Oh, I can see members. You're all going to get a coffee break. You're right. Look, we're only at the start of the winter and you've got a cold and a chest infection. This isn't good, is it? Lucy, you're not used to these agendas being so quick. Have they not arrived? No?
Not as yet.
Right, members, we'll go ahead without Councillor Martin because we said, he's here. He's here. No, you're quite all right. You're quite all right. We just want to move on. Right, sorry about that. We were all too quick on the first item, but let's continue as we started. We're moving on now, members, to having another update. We had an update at the September meeting on the winter planning and how the hospital was going to cope with what we know is going to be a very difficult winter. That was on September the whatever our date was, and I was bothered that this wouldn't work, if you remember, and I said, what happens if it doesn't work? We were told that they hoped it would. They got all the spreadsheets, and within 7 days, I could hardly believe it. There was a critical incident at NUH. So, presumably, ladies, you've come back to update us and also tell us what happened with the critical incident. Thank you. Over to you.
Thank you very much. So to introduce my colleague to those of you who've not met Caroline before, Caroline is our System Delivery Director for Urgent Care. So her entire working life is around managing urgent care. And for the purposes of the conversation, we will be talking about urgent care throughout Nottingham and Nottinghamshire. So it's not just NUH, it's Sherwood Forest Hospitals, it's community services, it's local authority services, and all the other things that support us managing our patients at greatest need. So I'm just going to do a quick introduction, and then Caroline is going to take you through some slides that just update you really. So as the chair said, we did present our winter plan in September, and in that we described the steps we're taking as a whole integrated care system to help our citizens reduce the need for urgent care in hospital, so that hospital facilities can be used to treat those most in need of clinical care. We really do want to help people stay safe and independent at home wherever possible, but also provide the best care for those in urgent need who need to be in hospital, and also use our hospital facilities to deal with things like planned care waiting lists and providing excellent cancer care. We know it takes all parts of our partners in our health and care system to pull together to make this happen. And that's including GPs, pharmacists, emergency departments, community services, social care, and the invaluable support of the voluntary community and social enterprise sector, and of course carers, to keep our system working as we want it to. We have for many years now had to develop a winter plan, but in reality, and I'm sure it feels like that particularly for Caroline, winter planning is a year-round endeavour. So we did present our plan in September, and as the chairs pointed out, members noted that almost immediately after we declared a critical incident. Now, I've been in the NHS for many years now, and critical incidents used to be highly unusual events, and we always think incredibly carefully as a whole system before taking the step to declare a critical incident. We've said in the paper that we've had two in this system, one in August, one in September, and to be clear that the September incident was both Sherwood Forest Hospitals and Nottingham University Hospitals feeling that they needed to find different ways of reducing and managing emergency flow. So whilst we are clearly, this is not a situation we ever want to find ourselves in, we do understand to some extent why the critical incident happened in September. And as the chair mentioned, we use quite sophisticated predictive analytics to look at what demand we will have for urgent care. So what illness there is in the population, how many staff we can expect to be at work or to be off sick, all the other things that affect demand for urgent care. And we look at that, and we look at what capacity we have in terms of hospital beds. And our analytics did tell us that in September, October, it could become quite tight. Demand rising, still got staff absent from annual leave and things, and we did acknowledge that things could get quite tight. Now, in acknowledging that and understanding that, we were already planning a number of mitigations that Caroline can describe in any amount of detail that you may wish her to prevent the beds becoming overutilised. And we feel that the reason that we had a critical incident in September is because those mitigations weren't quite in place at the time at which capacity outstripped demand. But we have learned from that as a system through the critical incident, and we have built our learning into our planning going forward. One thing that I am pleased to say is that our predictive analytics suggested both locally and nationally that we might have this twindemic in November, where we'd have rising flu rates, rising COVID rates, impact on staff absence. Things haven't actually, in that regard, locally and nationally panned out quite as badly as might have been predicted, and I can only imagine that's probably something to do with the success of vaccination programmes. So we look at our analytics the whole time. We look at what's really happening, and we adjust our plans. So just the thing I was going to add before I hand over to Caroline is, finding ourselves in critical incidents sadly is not something that's just happened in Nottinghamshire. It's happening across the country. So since we last presented to you, NHS England have mandated that as an integrated care board, we set up a 24/7, 365 day a year system control centre, and Caroline can explain that to you, but what that will do is enable us to have a dedicated resource, in addition to everything that we already do around urgent care resilience, to look at all of the factors that put our services under pressure, to work with our providers, to address in real time pressures that we're seeing in the system, and wherever possible, de-escalate the risk of crisis so that we don't find ourselves in critical incident in future. So I'm going to hand over to Caroline to talk to you more about how this is happening in practice.
Thank you. Caroline, welcome to the meeting. It's all yours.
Thank you. Could I have the next slide? So I'm Caroline Nolan, System Delivery Director for Urgent Care, work right across the Nottingham ICS, so dealing with 3 acutes actually in my portfolio, so NUH, Sherwood Forest and Bassett Law as well, so, and all of the other partners that Lucy mentioned. So it's quite a complex system. As you can imagine, there are 11 providers that we're coordinating the work of on a daily basis to try and keep people safe in Nottingham and Nottinghamshires when they need to access urgent emergency care. So it is quite a challenge. It's been a difficult year. I think it's fair to say it's been a difficult year across England and wider, actually, when you listen to the news. Significant pressure that hasn't really relented for urgent emergency care in a year where we're trying really hard to recover our elective work as well. So kind of 2 areas of pressure, but what we're trying to do is keep people as safe as possible and reduce harms as far as possible right across the board, so in both emergency and elective care. So I won't dwell on the critical incidents because Lucy's done that for us, but I do need to say that we do expect pressures to increase over the winter period. It happens every year. The modelling that Lucy referred to has built that in. We understand what winter demand looks like in Nottingham. We understand the impact of flu, and COVID is something we've also layered on. So we do expect it to be busier. And that is playing out. But what we can do to try and mitigate that is quite a lot of work around capacity planning. We can work well with our workforce to make sure we optimise their well-being so as we keep more of them at work. We can do lots of work around staff retention, recruitment, etc. And there's lots of work that we can do to improve flow, and that's about the processes that we put in place to enable people to move as seamlessly as possible and as quickly as possible through our urgent emergency care system. So that's what we're focusing on. And then the other area that we are building and working with partners really well on, which is the last bullet point on there, is around anticipating care needs. Now, I think there's more that both health and care can do around anticipatory care. There's a whole Ageing Well programme that looks exactly at that. And we are building that programme of work. And I think come 23, 24, we're going to start to see more impact of that. We're working with our primary care networks, we're working at place, we're working with social care, volunteer sector as well, to try and anticipate and prevent people feeling the need to access urgent and emergency care by providing better care for them in their community or at home. So a lot going on there, building up to some really good projects that we'll be implementing through 23 and 24. So that's the background. If we could have the next slide, please. Yeah, so a whole system plan kind of looks at three key areas. So demand and capacity being the first of them. So we've got projections that Lucy referred to that give us a very good indication of how many beds we're going to need across our system throughout winter. Looking better for the months of November, December and January than it did for September and October, and that's largely because we planned to put additional capacity in more towards the winter months. So we've got, for example, if I count the acute beds that we've opened for winter, we've got 190 additional acute beds across our hospitals to help support winter pressures. We've also put in additional services in the community. So urgent community response is a service that provides within 2 hours a response to people who maybe the ambulance services have visited or a GP seen, who we feel we could keep at home. We've invested quite heavily in that service. So that's about keeping people at home and giving them care at home, prevents them needing hospital treatment, but gives us capacity to keep people safe. So we've got quite a lot of plans around that we've built into our demand and capacity plans. The other things we do are obviously around vaccination. So we're working hard to make sure that we're vaccinating both against flu and COVID to prevent as many infections as possible. Our modelling based on what happened in the Southern Hemisphere shows that with high vaccination rates, you can have a big impact on hospital admissions for both flu and COVID. So we're progressing that at speed, and that's something we can all do, kind of spread the message around the importance of vaccination. So there's lots of measures that we've got in place. We've got some good modelling that's been done, and we've got some preventative work that each and every member of the population can kind of engage with to try and reduce that pressure. So that's a summary of the demand and capacity. If we could have the next slide, please. This one talks a little bit about flow and workforce. So flow is my world. So flow is the ability of services to complete their care interventions together as partners, so that people move from one care setting to another. Now that sounds quite technical, but if you think about it in terms of a person that calls an ambulance service, they've entered the flow of an urgent care system, and it's really important that we move people along that pathway as to the right part as quickly as possible and providing them with a good service. The issues occur in urgent care settings when part of that flow gets disrupted. Now, flow gets disrupted when you get backlogs, when you get queues. So you can easily see how a queue in one part of the system has a detrimental effect for people in another part. So if you take the example of a delayed discharge. So an elderly person who's ready to leave hospital needs a social care package or a residential home bed, and there's a delay accessing that for them for whatever reason. And we've got evidence of that today here in Nottingham. So that's a delay for a person. And that what the impact of those delayed discharges is that you will feel further back in the system, further delays. So the person that's delayed leaving hospital prevents the person that's in an ED department moving into a ward because the bed's blocked with that person who needs to get out. The person who's in the ED department taking up a bed or a chair, who rightly needs to be there, prevents the ambulance unloading the patient that's in an ambulance, and then worse still, it prevents the crew from being able to respond to the next call. So we work really hard in our system to make sure we unblock all those elements and address the backlogs that can occur. And I can give assurance that we're focusing on each bit of that flow. It's challenging because demand is for urgent and emergency care services is high. We aren't admitting as many people across Nottingham as we did pre-pandemic, but we're certainly seeing more people attend our emergency departments seeking urgent or emergency care. Most of which are appropriate. So we've got more to do, but I think it's just important that we appreciate that it needs a whole system response. We need partners to work together in this complex area, and we're all aligned, I think, across the ICS in doing the best we can for people to keep that flow going and to reduce the harm, because it is scary when ED is overcrowded and ambulances are struggling to get to their next case. But I think in Nottingham, we've got a very good philosophy working with our ED departments right across the board that we don't hold our ambulances, we try and hold that pressure in the ED departments. Now, that's not easy because it means we overcrowd ED, and that's when we see, you'd have seen it in the media, overcrowded trolleys queuing. But we've taken a decision as a system that that's less harmful than leaving ambulances queuing outside a hospital so they can't be released to go to the next 999 call. So this is complex. We haven't got a perfect solution, but I think what we are doing is making the best use that we can of the capacity that we've got, and we continue to work on our process improvements that mean we hand over quicker, that we discharge people quicker, that hospitals pull patients out of ED quicker onto the ward. We've got a process in place called the Bristol model that was nationally encouraged, where we're going one over on our wards. So as the patient that's ready to be discharged is brought into a waiting area, and one patient is brought from ED. So we really are focusing on process and flow right across the board. So that's a little mini lesson on process and flow. The other bit that we've got to talk about is our workforce. So our workforce are obviously part of our capacity, and that capacity depends on the capability, the availability, and the skills of our workforce. And there are challenges. There are challenges nationally across health and care to recruit to all of the vacant posts that we've got. So we do have vacancies that we're very keen to recruit to, but we can't always recruit qualified nurses. We can't always recruit care staff, consultants in all of the specialties that we want to. So that's the reality of health and social care at the moment. Yes, there's lots of work going on to address that, but we just need to be mindful. We're filling some of those gaps with bank and agency staff that come at a premium, and they're not part of the core workforce. But we recognise that's an issue, and we're working hard to try and improve that as well. But it's the reality of where we are this winter. If I could have the next slide, please. This slide is a pictorial, so you may or may not be able to see all of it. But what I've tried to do here is highlight the schemes that we've got in place right across the system. So the things that are in green prevent admissions to hospital. So just to pick out some of those, we've got a service in our ED department that meets the people that are what we call high intensity service users, who may attend ED quite frequently and may have some social needs that might be best dealt with in their community. So we've got a team of people that work in ED now called social care prescribers and navigators that kind of link with those patients and provide them a service at home to try and make sure they know how to access all of the things that are available to them more locally. So that's one example. Another one I haven't mentioned is 111. So we in Nottingham, we use DHU for our 111 service, and we've got a very high rate of clinical advice to that service. So we achieve about 60% of calls being given some clinical advice, not just a call handler advice. We've invested more in that, so as more people get the opportunity to speak to a clinician through that service. So that's another important development. We've invested in mental health support for 999, so as EMAS can work with some mental health specialists at their side in call handling centres. And we've also got some work going on in our care homes where we're working with EMAS to make sure the focus is always on keeping people at home if that's possible. So we're kind of doing an outreach service from community services, working with GPs and place to make sure we're doing an effective in-reach into our care homes as well. So, and then there's a hydration piece going on with care homes because we know that that has a big impact if we give people resident in care homes lots of drinks, make sure they're well hydrated and they're getting a good diet. We know that there's good evidence that that keeps them well and safe in their own home. So that's what sounds like quite a straightforward project, but it's actually a significant piece of work to work with all of our care homes right across the area to try and up the quality in that area. Not all care homes need it. Some of them are outstanding already, but we're working with those where we've identified we've got high rates of admissions from them. The areas in the turquoise blue are things that we're doing around hospital assessments and treatments. So things that are happening in our hospitals to try and keep flow moving this winter and forever, hopefully. So we are still focusing on making sure we are the best we can be in terms of ambulance turnaround. So we monitor that so closely. We investigate anybody that waits to be on the back of an ambulance to be taken into the ED department. We consider it very serious. We consider each and every one of those cases that may go over. It doesn't happen very often in Nottingham, but we do have some cases, a handful here and there, of people that might wait for an hour to get off the ambulance. In context, other areas are experiencing much longer delays than that, but I'm interested in getting it right for Nottingham and making sure we're doing everything possible to reduce the waits there. So working with our ED departments to do that. We're also doing a lot of infection prevention and control work, deep cleaning, etc., to try and minimise the risks around infection spread in the hospital. So there's additional work going on there. And then we're also, obviously, I mentioned the acute beds that we've brought online for winter, but we've also done that in mental health as well to make sure we've got enough capacity, both in terms of beds and the services to support people in the community. On discharge, we're using technology, so these are the dark blue areas, to monitor patients from home. So virtual wards is an example of that, where we take people out of hospital quicker, but perhaps give them some kits so as we can monitor their vital signs or their blood levels or something related to their condition. We've created 3 new discharge hubs this year. We've invested heavily in our Pathway 1 services to get people home, and we recognise there's more investment that we can do in home care, and subject to additional winter funding, we have a plan written to ensure that we bring more domiciliary home care capacity to our system, so working with social care quite closely on that. And then finally, just the next slide, please. Establishing a system control centre. So Lucy referenced this. This was a must-do that the ICB was asked to do, I think, middle of October. So over the last month, I've been dedicating quite a lot of time to establishing this 24/7 system control centre, where we will have kind of up to the probably 15-minute refresh data that will show us what ambulances are looking like what our ED departments are looking like, and beyond, what community services and waits for discharge into all our partners are looking like. What that will do is it gives us obviously a line of sight and the ability to take action right across the system on any key issues that are impacting patient flow, ambulance, safety, etc. So all partners are engaged in that, and we'll be using that information in our regular rhythm of the day. So we have regular meetings throughout the day with all of our partners. So we'll be using that information that's more real time, and our regulator is meeting with us every day to see how we're getting on with that, and to kind of point out the areas that we may need to do some focused work on. So that's already established in Nottingham. The formal system control centre goes live on the 1st of December, so we're building up to that. And so that's a little bit on the system control centre. And then finally, we ended last time, so I left this slide in about how can we kind of work together as a committee. So if we could have the next slide, please. So this is where I think where we can kind of work together. So I've just put them up as a reminder of the kinds of things that are helpful for us to work together on. And I think there's some work going on clearly in all areas of this. So it's working with our voluntary and community groups, and it's all of the work around access to food banks, travel, particularly with fuel poverty, etc. So yeah, they were the things to just remind everybody that that's what we can do together. So thank you.
Thank you, Caroline. That was quite a detailed briefing, but very useful, I'm sure, to members. Just one question from me before I just open it up. You say that you've factored in the COVID problems and the flu problems that could arise over the next couple of months. What is the situation like right now? Because I've heard from various people that there are a lot of COVID patients in hospital. So has it already affected elective surgery, or are you on target for that now? Because you obviously had a delay.
So COVID isn't at the peak that we thought we would get in November. So we were tracking a rate that we thought we'd be at based on the best evidence. We're not at that rate. So we're actually on the decline in terms of patients in hospital with COVID. There certainly is COVID in the community, but it's not having a big impact on the workings of the hospital. That isn't to say there aren't a number of people in hospital, but obviously we've become quite skilled at caring for people with COVID, doing the relevant isolation. Sometimes it causes issues on discharge, particularly to care homes who, are obviously quite nervous about patients being discharged with COVID. So we've still got a testing programme, etc., in place for that. Flu, we're seeing some increase in flu in line with where we expected it to be, but it's not. It's not causing us significant issues. It's not using more ITU capacity, etc., than we'd profiled for. So I think we're at levels better for COVID and where we expected to be for flu.
Right, Councillor Martin.
Thank you, Chair. Yeah, it's a myriad of complexity, isn't it? I suppose it was always inevitable that after 2 years of non-elective surgery, we were going to get a critical mass point, and that was going to come this year. Earlier this year, I was in Sherwood Forest Hospital talking to the chief exec there, and he said normally we get a peak in the winter and a trough in the summer, but this year we haven't had that trough because of the inevitable tidal wave of elective surgeries being delayed and the problems that causes you. I suppose the other side to it is as well is that now we've got an integrated care board, it should be smoother running, shouldn't it? Because we should be able to talk to other partners easier, and that was the whole concept behind it, and smoothing out some of those pathways. And it's great to hear that you've got such a finger on the pulse of it, because it is a changing situation constantly, and obviously the elective surgeries stop sometime around now and then start again in March, February. I suppose there are a few other changes across the county where mental health has moved to Mansfield from Bassett Law, so that's altering the schematics of Bassett Law's capacity, if that's included in Nottinghamshire now, because I believe it is, as part of the integrated care. Also, as well, they were getting £15 million for a new emergency village, weren't they? So that should help ease capacity. But I also would like to bring up the subject of urgency treatment centre at Newark, because obviously that's how do we go with elective surgeries there when there's no urgency treatment? Well, there is an urgency treatment centre, but you know it crosses the border with emergency department and urgent treatment care. And then forgot the other one was now. God, the other one's gone. But yeah, so you've got a rebalancing across the district, and I think Newark is one of the key players in that to keep pressure off not only Sherwood Forest Trust at Mansfield, but also at Queen's Medical, you know, and Bassett Law could help take the pressure off as well. So some of those rearrangements should be helping you, you know, and I wish you well in your path because it's a difficult one.
So I can probably address a few of those, and Caroline might want to add. So you are absolutely right. As an integrated care board, and we do have partner members on the integrated care board, so it's not just commissioners now. We have Chief Executive of Sherwood Forest sits on the Integrated Care Board, and the Chief Executive of the Mental Health Trust also sits on the Integrated Care Board. And I absolutely do think 3 months in that we do have really balanced conversations where we no longer think as organisations, we think as a system. Elective waiting lists are, you know, a little bit like urgent care. They are a problem across the country. We are making real inroads in Nottingham and Nottinghamshire to our longest waits, the 104-week waits, and a lot of that has been around what we just call mutual aid. So Sherwood Forest and Nottingham University Hospitals working together to make sure that we use the capacity that we've got on both sites and also in the independent sector to treat people according to priority. So we have a real focus on the 104-week waits over 2 years. We're now looking at 78-week waits. So I do. It does feel now like a single system way of managing waiting lists. Naturally, we don't stop all elective care in winter. We would never want to do that. We always do our highest priority. And picking up on the chair's comment about COVID, when we had COVID pre-vaccination, people getting very, very, very sick, and we had a lot of people in intensive care. We had to take a lot of our theatre capacity and do all sorts of things to create additional integrated intensive care capacity. That doesn't happen now. So we still have background incidents of COVID, but we don't have the surges into intensive care, which means that we can still do the more complex cancers and those sorts of things. So I think it is definitely working better. I think your points about Bassett Law Emergency Care Village, absolutely. The mental health inpatient move, I think, has been scrutinised here before, so I'm not going to talk about that. So Newark, absolutely, Newark is a key part of our hospital infrastructure. We are Sherwood Forest. We are working with them to build the amount of elective care that is done there, and we are doing more and more and more. And also, as you'll know, when Sherwood Forest as an acute hospital becomes under pressure, they will transfer patients over to Newark Hospital who perhaps live closer to Newark and don't need quite such acute care. So I would absolutely, we're hoping that next year we will come to you with our vision for Newark Hospital, but we can demonstrate, and I'm sure the Chief Exec explained to you, got a real aspiration to drive more elective activity through Newark Hospital.
Thank you, Lucy. Caroline, did you just add to that? Yeah.
I don't think so, no.
Thank you. Councillor Right.
Thank you, Chair. Yes. Yeah, I was just confusing you by moving around the room just to add to the. Yeah, thank you. Just thanks for the presentation. I just want to sort of ask a question around your system control centre, because that's sort of piqued my interest in regards to access. How try and put this in my term. There was a guy who I knew who had broke his ankle basically, and I had to get him somewhere pretty quickly to get his ankle looked at, and we had to take a decision of which place we were going to go to. Now I just wonder if there's any output on wait times that could be somehow appear on a portal somewhere visible to the public, that they could help their decision making from your public access, from your system control centre, to enable them to make better decision making. So the impact on you when you're already in, if you like, a difficult circumstance, could assist not only the patient in getting to the quickest location, but also in removing some of that pressure from yourselves also. That was it. Thanks.
Yeah, do you want to go first?
Yeah, thank you. I think it's a good idea. I think the only way that we probably provide that information right now to the public is through 111. So if you call 111, they will actually give you some information on what the waits are like in each of the acute trusts and the urgent treatment centres if you ask. I don't think that's kind of volunteered, but I think it's a good idea. So yeah, well I'll have a look at it. Yeah. Thank you, Councillor Pringle.
Thank you, Chairman. Caroline, thanks for that. Really positive. I've got three straightforward questions, really. We talked about the impact on the system. So my question is, which is more impactful, the staffing and the ambulance, lack of staffing of an ambulance facility, or the virus or a virus condition? Primarily, I'm thinking of the COVID and the flu virus with an immediate impact. That's my first question. My second question is, who's manning the control centre? And in manning the control centre, are they taken from another control centre? Because I'm assuming these will be skilled people, in which case will there be an impact on that control centre? And thirdly, with a magic wand, what two things would solve the issue in the flow problems if you could have those two wishes? Thank you, Chairman.
Shall I start?
Yes,
Yeah,
start,
yeah. So in terms of impact, our modelling quantifies what we think, what we think COVID will do to our acute bed demand. So we've got a count of everything really. So how many beds extra do you think we need because of COVID, flu, general winter stuff, and that kind of builds our profile. We then work on how we can mitigate for that through the various measures. There isn't one thing that would make a significant difference because it's about piecing the things together to get each bit of the flow working. So we'll never solve the ambulance issues if we don't put the investment that's required into discharge in terms of capacity, but also the bit in the middle where our staff work together, the processes they use to move people through the hospital and out into the care home. So I think I'm not dodging it, but I don't think there's one factor that I could say if I solved that, there wouldn't be any work to do today. I think that rightfully there are things to focus on in each bit of the system to do that. Yeah. In terms of manning the control centre, you're right, it does need skilled people to do that, people that understand what the data's saying to them, so they take the right actions and seek the right support at the right time. So I have a team of people that work with me, that the urgent and emergency care team, that are very skilled in that. We also train all of our on-call directors right across the ICB to be able to manage that in the out of hours period. So I've got quite a resource to call on that are already trained. We're seeking more support to that, so we're out for individuals that have got an interest in helping support this service through the winter period, and then we're looking to a longer term for recruitment to the control centre, because I think when it initially came out, we thought it was a winter initiative. It's become quite clear of late that it's actually going to be a feature of ICBs. So we're now turning our attention to think, what's the long-term plan for system control centres? So yeah, you're right about the training. You're right about you need some skilled staff, but we can train people to do this, because if they've got good information sources, you can almost train them through an action card scenario. So yeah. it's doable. It's a challenge at the moment, but it's doable. And if I had a wand and I could sorry, only two. Well, I've only got one because it would be the workforce. But that's my highest priority, because when you've got a skilled workforce and enough capacity in that would be my number one. Digital's the other, because I think there's more opportunity if we use digital more in health and social care as well. Yeah. So thank you.
Thank you, Caroline. Vice Chairman, are you able to speak long enough to?
I'll try. I might end up coughing. I think my point is basically mostly around communication and making sure that people use the right pathways, whether they go to the GP 111 or the hospital. Is there anything more we can do to make that more available for people? Because I still don't think people really understand what other services are available for them and when they can use them. And I don't know if it's something more of a Facebook thing for generations, or I just feel like we're missing something on the communication side of getting it out to people what other services they can use and what they should use.
Yeah, and again, Caroline might be able to give you a bit more detail, but clearly the winter plan that is for us as a health and care system is a complex set of interdependencies, and we need to, Caroline's team in particular, make sure it all works together. But that has to be communicated to our public. They don't need to know all those interdependencies. They just need to know, as your colleague said, where's the best place for me to go right now. So communications is a constant thing that we are updating. I don't know, Caroline, whether you've got anything that you could add around the winter plan comms.
Yeah, we work with all our partners on it. So there's a network of comms leads with the hospitals, with social care, with the ICB as well. And we produce a range of materials. And Facebook is one of them, but we don't seem to reach everybody. And it's hard to make sure you're reaching people right at the right time. So when you've got your mate with a broken ankle, it's a difficult one, and it's a job never complete. So but we work with our comms professionals on that. We use lots of different platforms for it. The campaign is live now around winter. It's focusing on care of your relatives, make sure you've had your vaccine, remember that 111's there. But yeah, I appreciate it's a job never finished, really.
Councillor Miles, just very quickly, I think it's 17.6 million pounds. How much?
Sorry, Councillor, can you use your microphone, please?
Sorry. How much slack between where we are today with the emergency care cases and a critical incident do we have?
So every day a hospital operates, if I take NUH, it has on average about 300 admissions a day. In order to retain flow, it needs 300 discharges if it's operating at 100% occupancy. We try and operate our hospitals not completely full. So as we've always got room in the vital services, so we always need a trauma bed, we always need ITU capacity. We need to be able to take people who are really at the high end of emergency to the right place. So in broad terms, you've always got to be able to match your admissions and discharges. You're in a better place when you've created more capacity by discharging more people than you've admitted. So in simple terms, if you have a bad day on discharge end, if you don't get enough people out on a Monday because you're picking up from the weekend, or there's been an issue related to, it could be any manner of things, and you end up with more admissions, you'll get a backlog. So it's a daily dynamic measure. So you've always got to at least match. We always aim to be over on the discharges, so as we're closer to optimum capacity. Hospitals run better when they're at 92% capacity than 95%, because you've got the ability to move people more freely. So yeah, we try and get to that, but the fuller you are, the tighter all of that becomes.
And probably just to add to your point, as of today, we are still continuing with all our planned activity, because that's the one of the main reasons you don't want to reach critical incident, because you will have to step down planned work and we are managing that at the moment.
Thank you, Lucy. Councillor Anderson.
Thank you, Chairman. We all know that healthy diet and exercise is important to a person's health and well-being, and also keeping them out of hospital. And since COVID, there has been a big impact on people's mental health. I just wondered whether patients were being made aware when they're discharged from hospital of the local offers to them, such as the exercise referral scheme and the food on our doorstep scheme, to keep people healthy and perhaps keep them out of hospital for longer. Thank you.
So specifically at the point of discharge, I think our hospital staff may not be able to provide kind of the detailed support that people might need other than through a leaflet because of the many places that people go to. But what we are doing is working in our communities at a place and at a very local level to reach out to entire populations and then segregating where we think there's more need to provide as much support as we can in our smaller output areas. So I'm aware of projects that are looking at that, wrapping support around people in their communities to try and address exactly the issues that you raise. I guess it's a fine balance between what we expect of the hospital to do in terms of treatment of their ill health and the acute emergency that they've been in hospital for, and what we can provide in a community setting through GP, primary care, community and other support services. But it's an important point, yeah.
Thank you, Caroline. Councillor Bailey.
Thank you very much. So my question comes in two parts almost. So in the documents, you cite that one of the factors of the critical incident being announced was the staffing. My question is, in terms of staffing, was there a slope downwards in the amount of staff available, or was it the fact that the amount of incidents, for example, COVID infections, when just kept on increasing to the point where the staff available just could not cope? So just which one or either or would be helpful. And in terms of just going forward, I know last meeting we mentioned quite a lot about the staffing and actually making sure staff was morale was kept high, staff was available, and actually the work that the ICB and the hospitals were doing to actually increase staff more was very, very important, not just for this winter but beyond. Now, obviously, we're aware that in terms of nurses, there is a potential strike. So I was just wondering if could comment on, will this impact in the immediate future or beyond? Thank you very much.
So Caroline might want to add on the critical incident. I suspect, as I recall, it was a combination of both. It was, when you go into winter, before people are fully into vaccinations, children go back to school. It was all around that kind of time. There will be more circulating instances of seasonal viruses in the population, and you will see, unfortunately, peaks and troughs of staff sickness. As I said, we do particularly well in our vaccinations in Nottinghamshire, both for our citizens and our staff. So we are holding our own. So it will have been a combination of factors that caused that particular issue at the end of September. So I think in answer to that would be what I would say. I don't really want to add to that. Yeah. In terms of industrial action, we are really clear that we want to reassure patients that emergency services will continue as normal, regardless of any industrial action. And we have tried and tested. I'm the Accounting Emergency Officer for the county and the city. We have tried and tested plans in place that we will enact if we need to, if there is industrial action. We do have to say, don't we, that industrial action is a matter for the government and the trade unions, but we do value our staff, and we do understand that good paying conditions are really important, not just for staff, but for their families and for wider issues like recruitment and retention. So we will do all that we can to support staff through a difficult winter, but we can absolutely guarantee that emergency services will be retained.
Thank you. Is Councillor
Thank you, Chairman. My first question was about the presentation. I couldn't see most of it. I wonder if it could be downloaded to the council so that we can make sure that we can see it at a later date. That's my first. The next one is about the trolleys. When an ambulance comes into the emergency section, it puts people onto trolleys. I'm just wondering what would, if the ambulance drivers and whoever saw the person assessed the person and couldn't find out what was wrong, and it could be a stroke or something like that, are they attended to straight away, or are they just put on a trolley in line with everyone else? I just wondered on that situation. I'm a very big believer on early intervention schemes, and I just wondered what more you could do as a hospital to make sure that people are aware of what they should be doing about obesity, what they should be doing about drug and alcohol abuse, what they should be doing incidents with the cold spell, and the COVID and flu problems, of course, with inoculations that many people are not taking. I just wondered what you could possibly help in that respect with notices or something to let people know that they're in the hospital, and yet they have the chance, really, of not being in the hospital. They had an early intervention scheme that could have helped them a great deal. I don't want to sound horrible, but were there any lives put at risk during this critical incident? The next question is.
Can you restrict your questions? Because we've got to go back to Councillor Martin.
Yeah.
Mindful of the time. And sometimes the questions are asked again in different ways. So can we just keep to the point?
Well, the point is, you said that you're looking at additional interim bed capacity in care and residential homes. Isn't that a very expensive way of doing things? Wouldn't it be better to look at other hospitals to see if they have got spare capacity? And my final question is about the 24/7 system control centre becoming operational. I just wondered where it was on that, where you were on that system, and will it operate on a permanent or a seasonal basis? Thank you.
So, if I just quickly address some of your questions, Councillor Wilmot. So, I know you are passionate about early intervention and prevention through your work on the Health and Wellbeing Board, and your colleague over there mentioned the range of services that are available in the community to support people both when they have been ill, or more importantly, to prevent people being ill. So we will be coming back to you actually at some point with our integrated care strategy that will hopefully describe to you how working together we are really going to focus on those early intervention schemes. So I think we've got a range of early intervention schemes which are very specific to individual places. We've got really good health inequalities data, and we do need to make sure that we target our populations and do exactly as you say. So that is, prevention is always better than cure. So we're absolutely committed to that. In terms of extra beds, I think what Caroline has described and what early intervention ends up with is you don't need beds. So actually, where we have to use care home beds to provide additional capacity for people, where we haven't managed to get the system working quite right, that is cheaper than hospital beds actually, but it's something that we're trying to move away from. So we certainly don't want to open additional hospital beds. We want to help people stay safe and well at home, and potentially avoid the need for hospital care. That would be our normal approach. I think in terms of pressures in ED and trolley weights and things, I'll just hand over to Caroline.
Yeah. So your concern around did patients get on the right pathway when they're brought in by an ambulance service. So the assessment starts at the point the paramedic would arrive at the patient's home. So they often know what's wrong with the patient. Sometimes they don't, but they know which pathway they're seeking when they get to hospital. So, for example, stroke patients are taken to specific areas, so thrombolysis can start rapidly. If that was missed, the first step when you arrive by ambulance is to a first contact assessment area where a clinician assesses you, and again vital signs are done. So in theory there are 2 steps that should keep people safe on that pathway. So that's as it sits today, and I think it's there are sometimes deviations from that, but they would be few and far between in my view. And the critical incident and harms, we know that when we don't treat patients as rapidly as our evidence suggests is the optimum, that harm may occur. So that is why we're focusing on making sure we move people as rapidly as possible from the ambulance through the ED department. So all of our measures are to try and reduce those waits. When areas are congested, I can give the assurance that our hospitals ensure that they bring enough care into the ED departments to manage the number of people that they've got there. So then bring workforce from the wards, from clinics, to make sure people's basic care needs, for example, are attended to. So yeah, we do everything we can to try and keep people as safe as possible, even when there is pressure and there are waits.
Thank you, Caroline. A quickie from you, Dr. Castello.
Yes, back to Councillor Eddie's point about informing people about making the right choice. I'm sure that it was around the launch of 111 that the NHS did some very simple style misdemeanor type posters that people could share on Facebook that directed them to the GP 111 or primary care or the hospital, before they called an ambulance, and they were quite simple. It was called The Right Choice, I'm sure it was. They were very simple posters, but obviously if people are more informed about the options available to them, it takes the pressure off you in the first place. So that's all I was going to say.
Sarah, did you want to speak?
Yes, I do, and sorry, I'll try and keep it really brief. So I've got a few things. First of all, virtual wards, applaud that. I think it's a great idea. But how is it going to be monitored around patient experience and promoting this service to patients and carers? I'm interested in the scale of investment on that and how we'll be fed back information on its efficacy. The other one is the System Control Centre. I think this, again, welcome this, but I would like to understand more about the transparency of that and whether details of how things are working can be fed to this committee to be used to give us better understanding of how things are working in the future. My big concern is around social care and flow, as you mentioned, to discharge. There's been issues at NUH, particularly where there's been over 200 patients medically fit to discharge, but the blockage has been into social care. So I'm wondering if, Chair, we could have an update specifically on social care mitigations for winter pressures in the future. And finally, the communications issues that other members have highlighted in ED, particularly at NUH. I think there's something there. Health Watch has worked with ED and has been doing a lot of work to understand the pressures that are there in terms of inappropriate attendance. And I think some of the comms needs to be targeted, particularly within our Black, Asian and minority ethnic communities and areas of multiple deprivation, because this is where people often culturally use hospitals rather than going to other types of services. But this does link to the issue of access to GPs, which again is another issue that I know this committee is very concerned about. And finally, a quick question for Lucy. In the September committee, we talked about VCSE being part of the mitigations, that's the voluntary and community sector. And I asked a question about modelling and whether there'd been some sort of communication with the sector, and I just wanted an update on that. But also maybe next year something about VCSE Senate or something that could be brought together to talk to the VCSE a lot earlier in winter pressure planning. Sorry, Noel, that was very fast. I know a few minutes.
If I just pick up a couple that I can answer, and thank you for reminding me actually about the involvement of the BCSE in our modelling. Oh, sorry. I do believe that when we look at our capacity planning, we look at everything that we can do to create capacity, and I do believe that will include some of the kind of more established things like British Red Cross, absolutely. So that will be factored into our capacity modelling. But I think your question is about how we do that more broadly. So my apologies, but I will come back to you on that. Is that all right? In terms of VCSE Summit, I think you know that Catherine McLean, the chair of the Integrated Care System, is really, really committed to the broader engagement of all system partners in everything that we do. And she's really keen, you know, she's got the reference group, the assembly. So I'm sure if there is a request, we can talk to comms colleagues about a VCSE Summit around winter planning. We would be happy to talk to you about how that we might make that happen. Comms, I think message is heard, and we do understand where we have differential access barriers, because it's all very well saying is that we've got all these services and we can direct you to them, but if people can't access them for whatever reasons, we have to be willing to differentially engage with those populations to help them to understand in a different way. So that is understood, and we know that GP access can be harder in areas that have multiple deprivation, and this is where I think we need to work with PCNs so that we're not relying on individual GPs, individual practices. What have we got? What are the network of services that we can wrap around GPs? So that is all very understood. System Control Centre, if we're honest, I think Caroline has said this, we are setting this up, and I think we probably do think it's a good thing. It's taking, but having that constant view, real time, of how everything's working together has to be a good thing, doesn't it? We're setting up at the moment in response to NHS England, because this is all part of integrated care boards owning their own populations, so they want to know that we're looking at everything across the board. So it is very much as being set up as a response to a national requirement, but I do think, as your colleague mentioned, as we become we're working out how it's going to operate, there has to be a way of saying this is what we need to manage the system, and how we can feed that back to committees like this to say this is how, based on what we know, this is how our populations can help as well. So yeah, certainly we're happy to do that. Probably just give us a bit of time to get set up and operating. So just virtual wards, Caroline.
Yeah, so virtual wards, it's a new venture. We've always operated some in community, but the acute part is new from the end of October. I've already seen some patient stories from that, so the team are definitely focused on that. But I'll probably need to do a little bit more digging to find out the method that they're using and whether it's the whole cohort and how they're doing that. But I know it's a feature within the plan. I just don't, at this moment in time, know how detailed it is. So I'll do some digging on that and I can let you know. Yeah.
Thank you very much, ladies. Well, I think we have aired as much as we can on this agenda item for the second month running. We have noticed the positive feedback that you have given to us, and thank you for that. And I take the message from this really that you'd like us to help you by making sure that when we see the public, we remind them about the vaccinations. Please. And remind them of what to do should they feel ill during the winter. It isn't necessarily that they go straight to a hospital. And I think the message from me on behalf of the committee is we wish you luck with winter. It's clearly difficult. I think everybody understands that, and you need support on this. And with the best will in the world, with all these spreadsheets and with everything, it isn't expected, I'm sure, to go to plan, because nothing ever does in this life. But we wish you well. Thank you very much. And obviously you're going to be busy during the next 2 months, because it's going to be your busy time. We meet on the 21st of February, and I wonder if you'd like to come back then and tell us whether your winter has been good, or whether it could have been better, or whether you found different ways for next year to work your winter. So can we ask you to come back on February the 21st of next year, which seems a very long time away, and we'll catch up with you on life in the hospitals during winter session. Thank you.
Thank you.
Thank you.
Caroline. I'm sure you've got to stick a life to
you.
And well done to Lucy.
Thank you. Yeah, thank you.
Thank you very much, everybody.
Thank you.
Thanks.
And then we'll move on to neonatal capacity, which we visited a year ago or so. And I'm just mindful of the time. Thank you, Caroline. Safe trip back. It didn't take a long time. Thank you. Nils was going to let the other people.
Oh, sorry. Apologies. On that one.
Hello, I'm Jenny Twin. I'm the Programme Director for the Maternity and Neonatal Redesign at Nottingham University Hospitals.
And I'm Leona Lee. I'm a consultant neonatologist and the clinical lead for the neonatal expansion.
So I'm just going to introduce this item and be brief. So it is exactly a year ago that Dr. Lee and I came to talk to you about the neonatal expansion, which comes on the back of national and regional reviews of neonatal capacity, and suggests that we need to increase neonatal capacity in our region. And the very helpful, unfortunate benefit of that is that that gives us the opportunity to increase capacity at Nottingham University hospitals, which will provide additional capacity regionally and therefore potentially for our own population. We described the fact that the additional investment is requiring some sort of capital reconfigurations and also a rebalancing of capacity from the City Hospital campus to the Queen's Medical Campus, but it is an overall quite significant increase in neonatal costs. We asked for the committees, when we came last time, Dr. Lee talked about the kind of pressures that are experienced clinically by operating with the level of capacity that we have now. And we asked for permission from this committee to proceed with our detailed planning to actually get this capital scheme up and running. And we wanted to give you the assurance that in moving forward without full public consultation, that we would, in developing our proposals, give due regard to the impact on our families and our patients and their families. So today's paper is to give you an update on where we are with actually making the capital changes real, and also receiving feedback from families of the patients that are cared for on the neonatal unit. So I'm going to hand over to Dr. Lee to do that. Thank you. Sorry, apologies.
So it will be me, and I'm going to give an update around the engagement and also an update on the programme because there have been some changes. So the purpose of the report before you today is to provide colleagues with an update on the targeted engagement undertaken by the Nottingham and Nottinghamshire Integrated Care Board in relation to the maternity and neonatal redesign programme. And I'll also provide an update to the overall programme approach and scope, which has changed from the outline business case originally discussed with colleagues last year. You'll see from the full engagement report attached to this paper that Nottingham and Nottinghamshire ICB have engaged with community groups, women and their families, health and social care professionals and the wider public, both within Nottingham and Nottinghamshire and also bordering counties, where families may access neonatal services to understand their views and experiences. The engagement team, to gather feedback, used a range of approaches, and engagement work commenced on the 27th of June this year and concluded on the 28th of July. The overarching aim of the targeted engagement work was to understand current experiences of service users and staff, and the main objectives of the targeted engagement were to provide patients, members of the public and carers with an opportunity to state what the neonatal and maternity services mean to them and how they want to access care, to provide primary care staff and providers an opportunity to feedback on the maternity and neonatal redesign programme, and to provide patients, members of the public and carers an opportunity to feedback their views on the planned expansion programme, to understand service users' experience of maternity and neonatal services, particularly those experiencing health inequalities, and to work in partnership with Healthwatch Nottingham to ensure we reach our communities, specifically our underserved and ethnic communities, and provide opportunities for them to provide feedback. Various approaches to gathering feedback were used, including an online survey, webinar. The engagement team attended forums in Newark and Sherwood and several groups in Mansfield, and around 20 parent views and opinions were recorded via face-to-face meetings. Throughout the engagement activities, a key theme emerging from all the engagement carried out was the extension of the neonatal facilities at QMC would be welcomed, and an improved spacious environment would be much better for both families and staff. It was also welcomed that the extension to capacity within the neonatal services would allow the service to meet the demand as required for neonatal babies moving forwards. Comments and feedback also recommended that the facility should be staffed appropriately with the right levels of experience and expertise. And we're working with the services involved with this programme and the Family Health Division at NUH to ensure a detailed and realistic workforce plan is created with an action plan and a strategy. There are ongoing activities to actively recruit staff ahead of the proposed opening of the unit in 2024, if approved by both the Trust and NHSE in the coming months. Engagement feedback from both families and staff around the plans to expand the neonatal facilities at QMC have been broadly positive, and families have fed back that their experience of neonatal care was good at both QMC and city hospitals, but that there are things that could be improved with the environment. The expansion plans will see a significant increase in space around each of the cots on the unit, and the adjustment to cot numbers at City Hospital will result in additional space to each of these cots as well. Families and staff will experience a greatly improved environment to work in and care for their babies at both neonatal units. If I can go on to a programme update, the outline business case for the maternity and neonatal redesign was approved through Trust Governance and then finally by NHSE in June of this year, subject to a number of conditions that are discharged within the full business case. The full business case is currently going through internal Trust Governance and will be heard at Trust Board on the 24th of this month for final approval before progressing to NHSE. The business case seeks approval for capital investment to enable us to deliver the proposed solution to the high number of neonatal babies and mothers who are transferred out of area and between City and QMC, and it will also enable the Trust to deliver care at a lower and safer level of throughput than it currently does. As you will already know, the key drivers for change are insufficient capacity, the need to respond to the National Critical Care Review, and the environment and space available on the neonatal unit at QMC is not fit for purpose. The M&R programme involves expansion of cots at QMC from 17 to 38, enabling it to retain its status as the lead intensive care centre for the region, the relocation of the highest acuity cots to the QMC from the City, and the redesignation of City to a local neonatal unit. There have been some changes since the OBC was drafted. The first one is that the updated staffing requirements for the M&R programme have been fully costed to ensure they meet correct national levels, and there is a separate BAPM case, which is the British Association of Perinatal Medicine, to support additional medical and AHP cover currently being discussed with specialised commissioning colleagues for funding. There is no longer a requirement to create 8 additional maternity beds at the QMC due to sufficient capacity in maternity beds across the broader trust, and the case seeks some additional staffing to support the opening of the existing beds across the service. The clinical pathways have been reviewed and updated to ensure that the flow and care of our women will be managed at the correct site for their needs. We are not currently expanding Theatre 2 in maternity due to being unable to decant the service at this time for the 9-month duration that the construction would require. Detailed quality impact assessments were worked through by the service, and the Trust will work up a separate capital case to look at expanding the theatre separately with alternative suitable decant plans. Capital costs are now higher than OBC, and the greatest cost pressure for us are inflation and market forces. And the revenue position of the programme is higher, and this is due to additional staffing being identified from the OBC and increased capital charges of depreciation and PDC dividend. The financial position is currently being discussed with specialist commissioning colleagues and the ICB. And finally, a complete decant of the neonatal service at QMC will be required while construction is undertaken. In order to enable the M&R programme to be constructed, the neonatal unit at QMC needs to decant. When the outline case was signed off by the Trust and NHSE, it contained a three-phased approach to construction that meant babies could remain in situ whilst construction was undertaken and completed. In April of this year, it became apparent that a phased construction approach was no longer a viable option for three key reasons. There's no ability to isolate medical gases within East Block, which is where the neonatal service is located at QMC, meaning that the neonatal unit would have to decamp for at least 6 weeks, even with a phased construction. Noise. Neonatal guidance outlines that noise levels should not exceed 40 decibels on a neonatal intensive care unit, and the planned construction works would be significantly greater than this. And the Queen's Medical Centre currently have a windows replacement scheme underway, and windows within the neonatal unit will need to be replaced, but there is a possibility of asbestos, meaning a potential decant would also be required even with a phased construction. There's a separate business case for the decant works going through the Trust Capital Programme alongside this business case, and the enabling works described in the case ensure that the decant areas are clinically suitable for the services and ensure that the M&R can safely progress. The case also contains appropriate staffing costs to ensure that the areas are safely staffed. This workforce is needed to support the fragmentation of services that will occur during the decant, and it is vital in providing a safe clinical environment during that decant. The clinical teams affected have written detailed quality impact assessments which have been through the Trust governance process and signed off. The decant plan is that the neonatal service will decant into the Nottingham Children's Hospital Surgical Unit per their business continuity plan. They have decanted there twice before successfully. It is still close enough to maternity to be a safe clinical option, and there is enough space to have 17 cots of activity, and no other area within the Trust would provide that. This will allow them to continue to operate at their current activity during the whole decant. Nottingham Children's Hospital Surgical Unit will decant into the following areas. They'll go into the pre-op onto B floor into some offices, which will be upgraded to meet the specifications required for pre-op. Surgery will move into ENT theatres, and the Trust has capacity to support this move and offer equivalent space to the services moving out. Post-op care will move to the ambulatory care unit, which is being upgraded to meet those specifications, and surgical admissions will move based opposite the ambulatory care unit in the Children's Hospital. The locations chosen for decant are the most clinically suitable options for each service. However, they do cause services to be fragmented. Limited activity will be lost by work to ENT, as we are ensuring they have like-for-like provision for activity. We will work closely with the services in the run-up to decant and during to ensure it fully meets the needs of all our clinical teams and the families affected by the temporary moves. The current high-level timeline for the programme is that we submit to NHSE England on the 28th of this month. It's heard at February JISC in 23. The decant programme would start with internal enabling works in January of 23. The M&R construction is planned to start on site on the 15th of September 23. Construction is due to be completed on the 11th of November 24, and we are planning to be fully operational and open on the 9th of December 2024.
Thank you. Did everybody hear that? I'm not sure that you did. I found it very difficult to hear. Quick canter through, and we non-medical people do have to have it a little bit clearer. So apologies if we haven't quite grasped the situation. The one thing I would like to ask you, because when I first took over the chairmanship of this committee, I was absolutely staggered to hear that neonatal machines weren't working, staff weren't trained to use them. So my question very much to you is, do we have neonatal monitors working at the moment, and do we have staff that know how to use them? Because you may recall, I know Lucy will, that it was myself that called for leadership to look at themselves and resign And one of the things was the fact that neonatal unit monitors were in the unit and people didn't know how to use them or they were broken. So I can see Lucy is absolutely itching to tell.
Yeah, no. So just for the committee's benefit, we're here today specifically to revisit the work that we've done to engage with the public on the expansion of neonatal services, and that's what we wanted to talk to you about. I think Jenny's given you quite a lot of detail about how NUH are developing their business case, but what we'd like today is to we'll get your support to continuing with this programme based on the fact that the overwhelming evidence, and I think when we came last time, Dr. Lee gave a really compelling case for the clinical benefits of this expansion. I remember Councillor Welsh being very supportive, and actually Councillor Welsh giving some, I know she's not here today, but some very positive feedback on the particularly the work of the neonatal nursing staff. So what we wanted to focus on today is whether you support us continued on the basis of the engagement report that we've shared with you, continuing on this direction of travel, which will reduce capacity at City, but as Jenny explained, create a better working environment for those and pet care environment for those children still cared for at City, but fundamentally put additional capacity in at the Queen's Medical site. So if we could focus on that particularly for today, that would be really helpful, and we'll worry about all the internal machinations of how we get access to money and things. So if we could focus on that. I mean, we do welcome your comments because it's quite a detailed engagement report, so still feel free to ask us any questions. I will definitely defer to Dr. Lee to give you a sort of an update on how the neonatal unit is running today. But what we want to talk about is how it can be in 2024.
Thank you, Chairman. Thank you, Lucy, for pointing out what this paper is for noting only. So it will be a question, not a voting paper. Jen, the only person that I know that's read the report that's actually broke the microphones because you were speaking that fast. No, appreciate what you're trying to get across in the timescale. Two questions, and again, I'm not Councillor Welsh, who was detailed in this report. It's new to me. And as you mentioned, yeah, I was concerned to read about the 116 babies which couldn't be accommodated in Nottingham. And that's referenced on page 44. But the data again goes from 2019 2020. Have we got any better updated information than that? My second question, I can see Dr. Lee there's bursting to get into me. My second question is that, and this is just one for clarity because I don't quite understand it. On page 54, it says 138 correspondents completed the survey. Well, that's 68 people were ethnically white, and it says that that's 92%. I'm not sure how that works out. I don't quite understand that percentage in that. Or could you clarify that? Is that 92% of the people who gave an answer? And also similarly, 65 people supporting the proposal. Was 80% one person, and therefore I suggest that one person opposing being 1%. How do we get to 72 people, adding up to 19%? I'm a little bit confused about that. So, thank you, Chair.
So yes, I think before Dr. Lee steps in, the numbers we are and we talked about, they came from our report in November that we brought to you in November 2021. So if you are able to give an update, thanks.
So those numbers, we still continue to transfer babies, both between sites, between Queen's and City, and also to transfer babies out of Nottingham, be that out of the Queen's neonatal unit or out of the City neonatal unit. So it's an ongoing problem. And the other side of that is that we continue not to accept babies from our network hospitals who require intensive care and ask for them to be transferred to another tertiary neonatal unit. So it is an ongoing problem.
It does directly. How do we correct it? Like, do we need to correct it? Am I missing something here? Sorry.
We need more cots and we need more staff and that's what we're trying to do.
We're back to the previous.
Yeah, absolutely.
Thank you, Chairman. I just wondered how many of these people that that are brought into the hospital could have had a home delivery, or is it so serious the situation that it would be impossible? And is there enough midwives in the area to accommodate a home delivery? You know, I would love to know that question, because you know, you're at capacity, total capacity. Is there any way of alleviating some of the problems? Is this one of the ways? You'll only know that. As you know, all NHS areas are losing staff at the present time, and it's at an increasing rate, and it takes, I don't know how long, is it 2-3 years to train somebody else to be able to do the necessary work. I wonder what steps you have in place to ensure that they are fully trained, that's the nurses, and equipped, to make sure there's enough equipped staffing capacity available for the expanded service. It's, you know, I just wondered on that situation. And of course, whether we like it or not, we've got to bring up parking situation again. We talk about it on every issue. It's a problem that you know, just will never seem to go away. And I just wondered, have you got any concerns about service users using the places that's provided? And is it possible, again, because I've asked this question once before, to put a specific area for the babies, well, not the babies, but the families, etc., in near to where the access to the hospital is? Thank you.
I'll just make a start, and then I think Dr. Lee can definitely talk to us about the steps that NUH is taking to ensure that you've got an adequate supply of neonatal nurses. So, just to be clear, Councillor Wilmot, we're not talking about our maternity services in general and the availability of home births and our midwifery. That's probably not something we're talking about here today. This is providing care to our sickest, most preterm babies who will always need hospital care. So there really is not an alternative setting for those babies, and we know that, you know, for all sorts of demographic reasons, there's more of them, and we need to provide that care. So we're not. So I don't think, in this context, the broader midwifery service is probably not quite relevant, but we do understand, you know, that broader question. Just before I sort of hand over to Dr. Lee to talk about how you work to develop your neonatal workforce, and I suspect it takes more than 2 or 3 years to train a skilled neonatal nurse. But parking, you quite rightly raised it. You continue to raise it, and actually interesting. You know, you're absolutely right. These are babies that could be in hospital for a long time. Families have to visit on a regular basis. There are financial methods of supporting people to access car parking, but we will never have enough car parking. I think, to respond to your question that you asked, I think in the stroke presentation, could we have dedicated, segregated areas for different specialty parking? I don't think it would ever work, genuinely. So I think the answer to that, I can't speak on behalf of NUH, but I think the answer to that is probably no. But absolutely, we do recognise the need to make, you know, it's not great, it's not good enough just to have great care. We have to make it so that people can access it. But I'm going to hand over to Dr. Lee, I think.
So, implicit in this plan is that we will have the required, make sure you can hear me, we will have the required number of staff and appropriately trained staff as well. To set us on this road, we've already started recruiting so that we can have sufficient nurses, and within that plan, streamlining their onward move into the qualified in speciality training, specifically for neonatal nursing. So that's a QIS course. And we have a dedicated recruitment and retention senior nurse who was leading on that, because it is so important that we have the right staff. And that team is also supported by a practice development team, and that practice development team are in charge of making sure that we keep our staff up to date, up to speed, and well trained.
Sorry, if I can just return to Councillor Pringle's point about stats. I have been looking at them. I haven't got my calculator out, but what if it's okay with you, we will provide an updated, because I think you are right. I don't think we can quite make those percentages work with the totals, so we'll come back to you on that. Is that all right? Thank you.
Before we finish, I will just remind you that on the 10th of January, we will we'll be revisiting the access to GP services, which is still rearing its ugly head. And we will have a response to how they're coping with COVID-19. And we'll be looking into the health visiting situation and whether they are returning face-to-face provision in the healthcare services. And we'll also be looking at the one subject that everybody keeps raising, and that is dentistry. So we'll be looking at that then, and we'll see where we go from there in 2023. Thank you to you, ladies, and thank you to you over there, Prima. And although we will be seeing each other before Christmas, can I wish all the committee members and our visitors a very pleasant Christmas, and most of all, a healthy new year. So thank you very much, everybody. Thank you.